Hello, hello. How are you guys? Welcome to another VMR. Today I will present a case, a very interesting case that I have the opportunity to solve. So I'm so very happy to be here today. It's like a therapy to me here in VMR at VMR. I'm feeling so comfortable and I love to be here and hope you enjoy. Sorry about the English. I, I will do my best, but I am so happy to present to you this case.
Oh my gosh, Amanda, your English is excellent. I heard your dog is speaking English too.
Oh, I'm teaching him speaking
Um,
English, but he don't understand.
I
He
think she
he,
said, I
he
think he said,
doesn't.
okay, pretty good. I heard, okay, pretty good. Anyway, one day I will make the clip that you sent to me yesterday public because it is one of the funniest things I've ever heard. But I'll keep us focused. Yeah, tell us about your interesting case, please.
So let's start. It's 67-year-old female with altered mental status and vomiting. So she presents with 2 weeks of progressive fatigue, poor appetite, and confusion, and now has nausea and vomiting. She had a left parotid gland swelling with concern of infections, parotitis, which was being treated outpatient with clindamycin and amoxicillin clavulanic acid.
Oh, what an unfortunate start. I think the reason many of us would be worried is because the patient's getting worse. I think before we talk about the case as a whole, I don't think we've ever had conversations about parotid swelling. So why don't we just slow down and take a moment just to think about that in detail? So I'd encourage you to reflect in the chat what your thoughts are about the parotid swelling and just share that, and we'll try to synergize what people are thinking. But I think I'll keep talking just so well, we keep the learning going about the other things. And so anytime that somebody is altered in vomiting, I think that the altered mental status takes precedent and should probably be the center of our conversation. Because if you imagine this case in real life, the patient is confused and is fatigued and lethargic and nauseous and vomiting. Of all those, the altered mental status is both the most specific feature and the most alarming, and that the brain is not working. And it's alarming in large part because of two reasons. One is the patient is young, on the younger side, so the probability of her having intrinsic brain issues is very, very small, meaning that her threshold to get brain disease is much, much, much higher because the probability she has underlying brain problems like Alzheimer's or Parkinson's is low. So her age is concerning. And I would also say there's another feature that's concerning, which is that she has 2 weeks of symptoms. Acute altered mental status is almost always as rapidly reversible as it began. Somebody has a seizure, anti-seizure medication. Somebody has a stroke medications. When something begins subacutely, it's much more likely to leave an intrinsic imprint in the actual organ. So the longer that something's been going on for, the more permanent it has, the more permanence it has. For example, somebody has had Alzheimer's dementia for 10 years. What are the chances that they won't have Alzheimer's dementia after 10 years? Somebody has hypoglycemia acutely, you're probably going to fix it. So subacute almost means that the problem is going to take significant precedent and has a chance of being permanent. So we have to to pay even more attention to that. So I think there's some fantastic thoughts in the chat about parotitis, including obstruction, infection, autoimmune from a whole variety of people. And I think it seems that the parotitis preceded the altered mental status because of the fact that the patient was well enough to get antibiotics. So if we're constructing our timeline, we have the 67-year-old person, We don't know anything about her yet, but we know she developed parotitis. And the interesting thing about parotitis first is to classify it as unilateral or bilateral. The differential diagnosis is so different for unilateral versus bilateral parotitis. That's the first step. Unilateral parotitis is either an infection or an obstruction until proven otherwise, especially if it's acute. Subacute or chronic unilateral parotitis is much more concerning for a space-occupying lesion such as a cancer. So here, I think we can assume that the patient has acute unilateral parotitis, prioritizing an infection or an obstruction, but we don't know that that's the actual problem yet. We haven't got enough details. And that's when you have to think about the microbiology of parotitis. There's a high rate of Staph aureus and a high rate of MRSA, methicillin-resistant Staph aureus. And so here, the antibiotics that the patient got covers MRSA, covers MSSA, and covers strep, but it does not cover some gram negatives that might be missed by this combination. So what would we be doing in real life? I think we have to be concerned that this patient is getting altered in a subacute manner. Subacute diseases are always sneaky and cause a lot of problems. We have to be concerned because she's young. And the parotitis might be true and unrelated, but the immediate most concerning hypothesis might be that she has a problem in her parotid that extended into her brain by direct extension. And so I think looking for signs like that on exam will be very, very important. All right, Amanda, tell us more.
So her husband was concerned of aspiration, and she has been spitting up after drink water at home. And within the last year, the patient has had 2 ICU stays for sepsis secondary to pneumonia. And in the past medical history, and she has a Drogen syndrome, chronic kidney disease, hypothyroidism, GERD, GERD, headless leg syndrome, HSV, aspergillosis resolved, and breast cancer in remission.
It's amazing how initially we were saying 67, parotitis, altered mental status, how her background is so rich and changes everything. And I think now it's a really, really good time for us to reflect on how this changes our calculus. So please share your thoughts in the chat. We'll try to highlight some. And the question is, what do we do with what we learn? I think the 2 most dominant conditions that we found is that she has Sjogren's syndrome. And Sjogren's syndrome is a chronic bilateral salivary gland disease. It does not explain the fact that she has unilateral parotitis. And so the question is, well, what are the complications of Sjogren's syndrome? And one potential complication is the patients with Sjogren's syndrome are at a markedly increased risk of developing lymphoma compared to the general population. And the lymphoma can arise really anywhere in the body, including the parotid gland. So I think you have to think, oh, wait, does this person have chronic inflammation in her parotid, and does that transition to a lymphoma? Unfortunately, that's not the only cancer she's at risk for, because breast cancer is one of the few cancers that has a persistent risk of recurrence even after being in remission, especially if the breast cancer is estrogen and progesterone receptor positive. Those cancers are notorious for maintaining the ability to recur in a delayed manner. There's actually a pretty short list for what kinds of cancers can come back after the 5-year mark, where often patients are considered to be cured if they haven't had recurrence. And those cancers are breast cancer, melanoma, and the primary ones are breast cancer and melanoma, though there's some other rare ones too, like a pituitary adenoma and a meningioma. So here, what has really changed, I think? What has changed is that the patient, now the previous baseline health of the patient is obviously not pristine. And the main conditions I think to pay attention to are her Sjogren's syndrome and her cancer history. And the fact that she seems to be immunocompromised enough to get 2 admissions for pneumonia, um, 2 admissions to get septic from pneumonia. So it's amazing how much this background has changed our calculus. And I think in real life, what would happen next? I think we learned a very important lesson every time that somebody's altered, to try to immediately know, are they altered with focality or altered without focal neurological signs? And that is going to be very, very important. The next step will also be to look closely at the medications list to see if there are any opiates for reversal, and then to get a finger stick glucose. So exam, glucose, and Narcan as part of Andrew Sanchez's great mnemonic scan. S for sugar, C for CT scan, if there's focality, A for airway and ABG, and then N for Narcan. All right, Amanda, tell us more, please.
So, one moment. She is a non-smoker, no alcohol use, surgical history, breast surgery in the past, and home medications, gabapentin, hydroxychloroquine, levothyroxine, omeprazole, prednisone, 5 milligrams, and valacyclovir. The physical exam of virus, temperature 38 Celsius, heart rate is 116, BP is 9/4, SpO2 is 97 in room air. Somnolent, mild stress, tachycardic, no murmur, no edema, no peripheral perfusion. Lungs, it's clear to auscultation, and we call breath sounds bilaterally. In neurological, normal, oriented to person and place, not time or situations.
Oh, wow, Amanda. So her neurological exam is completely normal. She's not sleepy. She's not lethargic. Oh, interesting. Okay. Well, I'm glad that the altered mental status isn't as bad as it might have seemed. But I think that if you look at the vital signs, this patient is meeting criteria for sepsis. So I would be really curious to get a poll and would want to learn from you all how you would empirically treat this patient. Yusuf and Yasmin are doing a really cool management reasoning session this Saturday at 4 p.m. Eastern. Highly recommend you join, and I think it's something we should try to percolate into all these VMRs. So the truth is, when you see these vital signs, you're going to have to empirically treat this patient. So share your thoughts about what your treatment strategy might be here, and I'll share my diagnostic thoughts and then summarize the treatment thoughts from the chat. I think diagnostically, we know now, and we should assume that this patient is infected. They have a fever, and fever in a potentially immunocompromised host is an infection until proven otherwise. Even though we might have specific clues as to where the patient might have an infection, we should always anchor ourselves in what the base rate of disease is. And the base rate would tell you that there's 6 very common places people get infected: lungs, skin, urine, liver, gallbladder, GI tract, and then bacteremia without a source. Here, there's no skin rash, there's no urinary symptoms, but the patient does have some respiratory symptoms. There's no, we'll have to wait for the liver labs to come back for hepatobiliary infections. We should get blood cultures to make sure the patient doesn't have bacteremia. And then, of course, have to worry, is her peritidis the problem? And does she have a parotid abscess? Or does she have extension of the peritidis into her brain? And her brain was important, but it's less important now because her exam is so reassuring. But when somebody has a history of HSV, you have to worry, do they have HSV issues in their brain? So, yeah, I think there's a fantastic management reasoning here where everyone is thinking fluids, antibiotics. There's a lot of difference in opinion about what antibiotics to use, but people are generally very broad right now. MRSA coverage, gram-negative coverage, and fluids for the patient. And I'll ask you all now one important management reasoning thing, which is you give this patient fluids, you give this patient antibiotics, 2 liters, 3 liters of fluid, but her blood pressure doesn't budge at all. Hypothetically, let's take a minute to think about that, practice that. 1 liter, 2 liters, 3 liters, antibiotics, her blood pressure doesn't budge. What medication might you consider giving this patient? Awesome. Noah's saying pressors. What about her medical history might make you think of a specific medication to use? Amazing. I think that when you have a patient with autoimmune history, like Sjogren's, who has fever and persistent hypotension, you should think about adrenal insufficiency very early. One of your first thoughts, honestly. So here, the usual algorithm for worsening sepsis is IV fluids, antibiotics, so on and so forth. But I think a patient like this, we have to think about adrenal insufficiency early on, much earlier than we would otherwise. So I think our consensus is a broad infectious workup, antibiotics, fluids, and see where the lab data takes us. All righty, Amanda, tell us more.
In her labs, WBC was 31K, hemoglobin is 11, hematocrit 35, platelets is 500, sodium 144, potassium 3.7, chloride is 125, CO2 8, BUN 42, creatinine 2.4, anion gap 11, calcium 10.7, magnesium 2.1. I will give more.
Yeah, very helpful, Amanda. Yusuf is sharing a lot of a really cool fact about steroids and in severe sepsis, and has a link in Twitter. Thank you, Yusuf, for that. I didn't know this. I can't wait to check it out more. And Mattie's immediate response is, "What's the diff on the white count?" And I think that's absolutely superb. If you assume that you don't have that there's a little bit of a delay in the diff, and Amanda's holding that, I think you have to make sure that, and you have to assume it's neutrophilic until proven otherwise. And then hopefully you can get that data to make sure you're not making an assumption. So if this is neutrophilic, I think the first assumption is that this patient has pus under pressure. The most common cause of a leukomoid reaction, defined as a white count over 30, is the patient has pus that is blocked somewhere, either in her parotid or in her lungs as a post-obstructive pneumonia, or in her abdomen. And I think that should be the first assumption. And that assumption is reinforced by her platelet count, which is also high and also features a lot of pus under pressure. So reflex response to high white count like this, pus under pressure. Where is it? Her her electrolytes are fascinating. Amanda, maybe just one question, because that otherwise I'll talk forever. What's her baseline creatinine? Is she more, because you said she has CKD? Is this baseline or high or?
No, it's the baseline.
It's baseline. Okay, look at this baseline. Look at this renal panel, y'all. She has no AKI. Her anion gap is only 11, yet her CO2 is 8. So she has a low CO2. What do you all think about that? What does that mean? Curious. What's your reflex when you see a CO2 that's low? Yeah, Hans, very, very good. I think you might immediately think, oh, she has a non-gap anion. She has a non-gap anion. She has a non-gap metabolic acidosis. Excuse me. But you don't know that we don't know yet that she doesn't have a respiratory alkalosis. She's hyperventilating, and her CO2 is lower as a compensatory issue. But if you look at her respiratory rate, it wasn't that impressive, right? Her respiratory rate wasn't that high. And to have a compensatory CO2 drop down all the way to 8 would be very, very extreme. So I think you have to run your differential diagnosis for a non-anion gap metabolic acidosis, but you can wait until you confirm with a pH to see if she has a compensatory drop in her CO2 or a non-gap metabolic acidosis. And I think Alec has made a fantastic point. Alec, are you able to share that point out loud?
Sure. Yeah. I mean, I think the number of 8 for the CO2 in itself is so impressive, but it's hard to really interpret without the context of the pH, and so that will be critical in our next steps. But somebody's that critically ill like this, you need to check the lactate, be sure that this isn't something else that's going on. And then Sjogren's, just as an aside, can really cause some problems in the tubules. More commonly, I believe, in the distal tubule, causing a type 2 RTA or a distal RTA. And the urine will be very helpful to look at the urine pH and some of the urine electrolytes as well to see where we're at. But it's very helpful that you asked about how far this creatinine is off of her baseline, because that can affect things as well. But yeah, we just need more info, and that can really help us on our journey here. Is this just a part of her critical illness, and lactate will be very high, or if this is something that has been going on for a long time? And I think with her CKD, there can be some chronic acidosis related to that. And then, it would be helpful to know what her baseline CO2 is as well, just to see how far off we are.
Yeah, no, I absolutely love it. I think that's superb. Thank you for that. All right, Amanda, tell us more, please.
AGFR was 21. Alkaline phosphatates is 232. Albumin 3.6. Hepatic panel is unremarkable. Procalcitonin 10. Lactic acid 1.2. Troponin 1, 0.02. And we have ABG. pH 7.16. PCO2 17.4. PO2 106. Bicarbonate 6.1, and basis deficit is -23.
Anyone want to take a crack at interpreting this ABG? Anybody? Please share your thoughts in the chat. I think it would be very, very helpful. I'll just summarize the rest of the data. I think this patient is so critically ill that maybe some of this data won't stick with you too much. Her alk phos being elevated should make you wonder briefly if she has hepatobiliary disease, but it's unusual to see just an alk phos without a bilirubin elevation or AST elevation or an ALT elevation. So I'm not sure if that alk phos represents bony issues or liver issues. It is also worthy to make note on the rarer side that Sjogren's syndrome is associated with PBC, or primary biliary cholangitis. So that might be a link just to keep in your back pocket. Procalcitonin of 10 is basically very, very high and points us towards a bacterial infection, but it's not perfect. It's flawed. So I thought the rest of the data is in line with the rest of the data that we have here. Lactic acid, the troponin is probably not too impressive. Yeah, Ricardo, do you want to share your thoughts out loud?
Sure. Yeah, so the anion gap, well, first the pH is acidic, so it's 7.16. Then with the winter formula, 1.5, we multiply 1.5 times the bicarbonate, and then plus 8 with a margin of 2. So it will be 1.5 times 6.1, which is bicarbonate. So it will be around 9. Then plus 8, 17. And we see that the PCO2 is 17. So it's compensated. And the metabolic acidosis and the anion gap will be sodium minus the sum of chloride and bicarbonate. So it will be 144 minus 131, and that will be around 13. So greater than 12.
Yeah, I think you nailed it. You start with, this patient has acidosis. And the question is it metabolic or respiratory? And when the bicarb is low and the CO2 is low, it's metabolic. And then the question is it anion gap or gap? And Amanda told us that it's a non-gap acidosis. And then the next question is there appropriate compensation? And you went through Winter's formula. So you're right. This is a pure non-gap acidosis with respiratory compensation. So now it begs us to think about what's our differential diagnosis for a non-anion gap metabolic acidosis. But let's put some management reasoning on. Before, we wanted to give antibiotics, IV fluids. I have a question for you all now. What kind of IV fluids do you want to give this patient and why? What kinds of fluids should we give her, you think? All right, Yusuf, tell us out loud. I'm assuming it's you. I think it's the CP Solver's account. So let me know. Yeah, is it you?
It is.
Okay, good. Yeah, so why did you choose lactated ringers?
Normal saline is associated with hyperchloremic normal anion gap metabolic acidosis, which is what we see in this patient. Although if we take septic shock on its own, there's no significant difference between LR and NS. It's usually the fluid that you can reach for most easily. But ideally, if you can have both options, I would choose LR to avoid the hyperchloremic metabolic acidosis.
I absolutely love it. I think that's superb. I'll also take liberty to lean on my friends who have their videos on. So I'm just curious what people's thoughts are on what their DDX is in general for a non-anion gap metabolic acidosis. Oh, Ricardo, I'm not sure. Amanda told us the anion gap is 11. That's what I'm going on. You can unmute, Amanda. That's okay. What is it? What is the anion gap?
It's 11, so it's normal.
Normal. Okay. All righty. Cool. I can't do math in front of a crowd, Ricardo. I'll just trust Amanda. I'm impressed that you were able to do it, honestly. All right, Aisha, what do you tell us what you're thinking?
Oh, I'm a little confused about this case, so I wouldn't be able to give a definitive diagnosis.
Oh, no, sorry. I don't mean to put you on the spot for the diagnosis. I think that would be superhuman. I'm curious what we can focus our thoughts on what you think of when you hear non-anion gap acidosis in general. What are the diagnoses you consider, not in this patient, but what causes the non-anion gap metabolic acidosis?
It would be hyperchloremia, especially because hers is pretty high.
Yeah.
Renal tubular acidosis, considering she has CKD and her creatinine baseline is high. I'm not sure she had nausea, but I'm not sure if she had any diarrhea. No, she didn't have any diarrhea.
Oh, excellent.
And Addison's disease, just because she is she could have autoimmune disease other than Sjogren's.
Yeah.
And hypothyroidism as well.
Yeah, absolutely. I think if you were to play base rate, the most common causes of a non-anion gap metabolic acidosis, there's 3 of them. The first would be the patient has diarrhea. The second is the patient got anion gap metabolic acidosis from us because we gave her normal saline. And the third is CKD. So if you're being practical, you're like, does she have a non-gap? Does she have diarrhea? No. Does she get normal saline? No. Does she have CKD? Yes. But then if you adjust for the degree of CKD, the degree of non-gap acidosis is way out of proportion to the degree of CKD. So she must have another cause. And as Alec and now Mingyu are reminding us, you have to think of renal tubular acidosis in this patient for sure. And I think the way you would go about doing that and clarifying that is to get urine anion gap to help understand the possibility of RTA. There are some other things that can cause a renal tubular acidosis that are rare, and the short list is D-lactate acidosis, ketosis can do it too, and then ingestion of toluene, which none of which are at play here. So I think the focus is, does this patient have an RTA? But you have to be careful. How does her RTA link to her fever and tachycardia and hypotension? And that's where people are thinking adrenal insufficiency. But let's not remember, she might have an infection and her RTA is chronic and completely unrelated to what's going on acutely. All right, Amanda, let's know what you have.
We have our urine analysis, pH 6, positive for protein 30, trace ketones, and moderate blood. Negative nitrites and leukocytes, sterase, WBC6, and hair bacteria. We have imagings too. CT for head, max and face. It's non-acute intracranial abdominalities, left parotid gland enlargement, and a CT chest with patch or space disease, which in both lower lobes and right middle lobe, suggesting multifocal infection.
Yeah, and I think that I think this aliquot basically tells you that you really should consider treating her for pneumonia, as you all did originally. And I think the key question is, why is she getting recurrent pneumonias over and over and over again? And that might be because she actually is getting recurrent pneumonias, or she has a disease, that's mimicking pneumonia. But here, I think acutely, you would probably narrow your antibiotics towards pneumonia and see how she does. It's weird that the left parotid gland is enlarged and enhanced, and that there is no focal collection. And I think that brings into the possibility that she might have Sjogren's related lymphoma. So yeah, I think what would I do next in real life? I think that you'd probably give her antibiotics and see what happens to her fever, tachycardia, and hypotension. But we're getting some themes that there might be multiple diagnoses here. Does she have an RTA from Sjogren's? Does she have a lymphoma from Sjogren's? And does she have an infection? And those things aren't mutually exclusive. They may all be related. Yeah. Tell us, Amanda, what other data you had.
So the patient was admitted to the ICU when I learned about her case, and correction of her acidosis with a bicarbonate drip. Her blood pressure improved with a fluid bolus, and she was started on cefepime and vancomycin for presumed sepsis with pulmonary focus. In the additional labs, the nephrology was concerned in the urine electrolytes in sodium 75, potassium it was 15, chloride is 7.6 with an increased urine annual gap, it's 14. And repeat with treatment and weight, we repeat the BMP, showed a CO2 of 18 and potassium 3.2, sodium of 146, and we had cultures. C. diff toxin was negative, positive EGM and EGG for Mycoplasma pneumoniae antibody, and MRSA swab negative. Now, final diagnosis is pneumonia for Mycoplasma. And we have a case of, in the course, the renal tubular acidosis too.
Amanda, I think the last piece of data that you gave us is really interesting. And I think we can take some time to think about that. So, yeah, maybe we've never had or talked about renal tubular acidosis and virtual morning report. And I think they can get very confusing. There's 3 of them, even though there are 4 names. There's RTA1, RTA2, and RTA type 4. And it's hard to know how to begin to have this conversation, but to tell you that RTA type 2 is confusing. RTA type 2 is proximal renal tubular acidosis. And in RTA type 2, the bicarb is just a small piece of the puzzle because it's often accompanied by other electrolyte wasting, phosphorus wasting, uric acid wasting, glucose wasting. So proximal renal tubular acidosis is really bicarb plus other things. Now, why is proximal different? Proximal is different because it has absolutely nothing to do with ammonia. Ammonia is the key molecule associated with the distal RTAs. So when you're trying to diagnose RTA, you're chasing one of 2 things. Either the patient has a non-gap acidosis along with other electrolytes or molecules that are being wasted, glucose, phosphorus, uric acid, or you're trying to chase ammonia. So let's play that game here. Here, the patient has a normal phosphorus, no glucosuria, and we don't have a uric acid, but there's no evidence of a proximal RTA. So the question is, does the patient have a distal RTA? And the question then becomes, it's all about ammonia. So what does ammonia have to do with the distal RTA? The ammonia is ammonia generation is what allows us to comfortably excrete acid. And the deficiency in ammonia generation and ammonia binding a proton results in a non-gap acidosis. So all the distal RTAs have to do with a deficiency in ammonia. Unfortunately, we cannot directly measure urinary ammonia. We can't directly measure it. So we have to use other things to see if it's there. So that's where the urine anion gap comes into play. The urine anion gap comes into play because we cannot measure urinary ammonia. So what do we do instead? We realize that urinary ammonia, NH4 plus, is a positive molecule. And we calculate the urine anion gap, where we subtract all the electrolytes from each other and we see what's left. We take the urine sodium, the urine potassium, the urine chloride, and here we get 14, a positive number. Normally, in the presence of, if ammonia was present, a positively charged entity, this gets confusing. You really have to pay attention to the words. Ammonia is positively charged. If you calculate the urine anion gap, it should be negative in the presence of ammonia. Why? A negative anion gap picks up the presence of a cation, a positive ion ammonia. Now we do this all wrong. We should just look for the urine cation gap, which would be positive. But the way we measure it for some reason is the urine anion gap. The urine anion gap is negative, suggesting the presence of a positive cation. If the urine anion is positive, there is a urine anion that's missing, then there's no ammonia. So here, Amanda calculates this and says the urine anion gap is positive. That means there's been an accumulation of a positive of NH4 positive, NH4 plus. Okay, so normally the urine anion gap should be negative, and when it's positive, it suggests a deficiency of ammonia. This is not the best test. The urine osmolar gap is more specific for ammonia. Why? There are many things that can cause a positive urine anion gap. Having lost ammonia is no different than having gained an anion. The differential diagnosis for a positive urine anion gap is a loss of a positive charge or a gain of a negative charge. So what are the other things that cause a positive urine anion gap? It's when you have ketones in the urine. It's when you have lactate in the urine. The only cause of an elevated urine osmolar gap is ammonia. So let's step back after I said that once. Say it one more time. Teaching RTA is one of the hardest things to do. Proximal RTA, low bicarb and low bicarb friends, low glucose, low phosphorus, so on and so forth. Distal RTA, it's all about ammonia. NH4 plus. How do we detect ammonia? We can't measure it, unfortunately. I wish we could. So we remember its characteristic features. It is a positively charged entity. When we calculate the urine anion gap, we expect the urine anion gap to be negative when there's ammonia because a positive charge makes the anion gap negative. So when the anion gap is positive, that tells us there's too many anions compared to the cations, often reflecting a deficiency in ammonia, but can also reflect accumulation of negative charges. Because there is a DDX, we can follow that up and get the urine osm gap, which would be positive in the case of the presence of ammonia and would be normal or negative if there is no ammonia. Okay, so this will require a lot of reading and a lot of reflection, but the fundamental facts are ammonia is positively charged. When you calculate the urine anion gap, if ammonia is present and it's positive, it should make the anion gap negative because there is no gap in the anions. There's a lot of ammonia, it's positive. If ammonia is absent, gone, then the urine anion gap becomes positive because there's less NH4 plus to make it that way. Okay, it gets very, very confusing, but I hope you can get some practice. And as Austin and Mengyu reminded us, this patient probably has it from the Sjogren's syndrome that she has. Now, we didn't talk about RTA type 1 and RTA, the distal RTAs. There's two types, type 1 and type 4. That's too much to talk about now, but I'll tell you the potassium is the distinction. RTA type 1, which is more associated with Sjogren's, features hypokalemia. RTA type 4, which is not associated with Sjogren's as much, usually features hyperkalemia, high potassium. A high amount of ammonia in the urine makes the anion gap negative and makes the osmolar gap positive. A deficiency in ammonia causes the urine anion gap to become positive and the urine osmolar gap to fade away and become 0 or negative. Amanda, you made me teach about RTA. Oh my gosh. I wasn't ready. I needed some warning before.
It was beautiful and incredible.
no.
I have so many difficulties in renal system, and you give a show. Shine, shine, shine. Congrats. I love it.
Oh, and the star of the show is you, my friend. Such an incredibly educational case. There's so much simple things here. You're teaching us pneumonia, and in older adults, you taught us not to ignore mycoplasma, which is a really nice lesson here. I'm not supposed to do what I'm about to do because some of you may know we have a website. Reza and I have a website, rlrcpsolvers.com, where we share all these exclusive schemas. And this, I'm going to post the RTA one to that soon. And because that is behind a paywall, we're trying not to share these schemas, but I think this is too complicated a subject. So I will try to show it to you visually so you can see this concept with your eyes. And if you can, please consider checking out rlrcpsolvers.com. It really helps us a lot doing what we're doing. But I'll break the rules today and show you this picture. Told you RTA is all about urine ammonia. If the anion gap, the urine anion gap is negative, ammonia is present. If urine anion gap is positive, there's too many anions, then it's absent. Or there are other anions like lactate, toluene, ketones. The urine osmolar gap positive, there's ammonia. Urine osmolar gap negative, no ammonia. Okay, this is a better test than this. And for many more schemas and advanced concepts, you should check out rlrcpsrs.com. But it is behind a paywall. And that paywall helps us do all the things that you're seeing now and others. Okay, Amanda, I'll stop talking. What before we pass the mic to one of our newest team members, Hui Ting, I'd love for you to share what you learned and what your reflections are from this case.
So what I learned and I loved about this case, it's more about medicine, how I love this communication with the physicians, like nephrologists. We consult the ID and the critical care physicians. It's beautiful and amazing. And what makes me study and bring this case, it's about the many diagnoses the patient have. So we can explore in one patient a lot of diagnoses. And it's very incredible, and I love. And renal, it's my unlike, it's my, I don't like much, but in this case, I learned a lot from him, from this case about about renal tubular acidosis. And it was incredible, and I have to share to you this case. And I learned so much today.
You're the absolute best, and this is such an educational case, and so much. I love the combination of bread and butter, simple fluids, antibiotics, pneumonia, and then some fancy smancy RTA. Thank you, Amanda. All right.
Oh.
Yeah, go ahead, please.
There was a question about why this patient has pneumonia.
Oh yeah.
We just thought it was because her is a immunosuppression patient, so maybe from this immunosuppression she has a lot of cases of pneumonia.
Yeah, I completely agree. I think that makes a lot of sense. And honestly, Amanda, I was just going to say, I hope that in watching you and sharing how honest you are about how much work it takes you to be comfortable speaking medical English and to do so publicly, I hope and believe that you've inspired people here and people listening on YouTube to realize that we're all just here learning and growing and sharing our wisdom. And a lot of us have many hurdles that we have to jump through to be here, and a lot of anxiety and nervousness and whatnot. And your bravery and your commitment to learning and growing is so admirable. And I'm sure it would make you so happy to know that you helped somebody in the audience get a little bit more confidence to share their case and their learning. So y'all, I really hope that you see this as a space that invites you and welcomes you to present a case. And Amanda's been working on her English so hard and so deliberately. She's even been teaching her dog English. And so really hope that you all feel more and more comfortable to bring your cases and collaborate and learn from each other. And so ask yourself, if you haven't presented on VMR, ask yourself why. And I think sitting with that and conquering that fear is important, and doing so in a space that encourages that and will never bite back, but rather spread the joy. So I think about challenging yourself to answer that question. Definitely many people have enjoyed VMR for years without ever presenting a case, and there's no pressure at all. But often we can be our own worst enemy sometimes in terms of letting our skills flourish and grow. So if any of you are on the fence, we really are here to help you cross that fence and feel more free and more, feel more free, as free as Amanda. Thank you, my friend. All right,
Thank
Hiting.
you.
Yeah, take it away, please.
Yeah, oh my God, thank you for a great discussion. Oh my God, this is like a really good case presentation. I think I barely can keep up. So much information. So thank you so much, Amanda and Ravi. It's great, your discussion. So this patient, her chief complaint is altered mental status and vomiting. So when it comes to altered mental status, that is the most specific and most alarming feature in this case. So when it comes to altered mental status, so we have to see if it's something acute or subacute. In the case of something acute, can be some deficiency electrolyte, and that should be rapidly reversible. But in the case of a subacute altered mental status, that could leave a more intrinsic imprint. And if it's happens a longer time, there is more chance to become more permanent. Okay, and when it comes to infection in the parotid, we have to ask if it's something unilateral or bilateral. When it comes to its unilateral, we think about infection, and that can be methicillin-resistant Staph aureus or strep infection. And the concern about the infection of the parotid is the dissemination to the brain. And or it can be also a cause of obstruction or occupying space. Okay, and when it comes to, and this patient has past medical history that help with the case, which is the Sjogren's syndrome. And Sjogren's syndrome usually is a bilateral glandular disease, and one of the complications is there's an increased risk of lymphoma. And also this patient has cancer history, which is a risk of breast cancer. And that will be a high chances for recurrence. And one of the main type of cancer, primary cancer, include breast cancer, melanoma, and meningioma. And also we recap a mnemonic for altered mental status, which is a scan. S stand for sugar, C stand for CT scan, A stand for airway ABG, and N Narcan. And when it comes to the management, in this case, we want to do the broad spectrum antibiotics, and also we use fluid. And in the case that we need to avoid the use of normal saline because that increase the chance of the non-anion gap metabolic acidosis. Okay, and if in the case that the blood pressure doesn't change with the treatment, we have to consider in this case, because there's an autoimmune history, fever or persistent hypotension, we need to think very soon an adrenal insufficiency. Okay. And the case of an elevated white blood cell, we need to think of maybe there's a pulse under pressure, and we need to ask where's the location. Is it a parotid or is it in lung? And of course, when in the result of the CO2 and low CO2, we think about the non-ion gap metabolic acidosis, and the causes can be diarrhea, or the patient received a normal saline or CKD. And the alkaline phosphatase elevated, that could mean hepatocellular disease. And also the elevated procalcitonin, that is a result of a non-specific infection. And we need to remember that the metabolic acidosis usually is low pH and bicarbonate. And if there's a recurrence pneumonia, we think about maybe it's a RTA or lymphoma, and all this could be related to Sjogren. And of course, Ravi taught about the RTA, but I think it's too long, so to catch up everything. So I tried to just I wrote the main points. So yes, so RTA type 2 is proximal, so usually it's a low bicarbonate, phosphate, glucose, wasting, but nothing to do with ammonia. So when we see deficiency in ammonia, now we think about the RTA distal. And this cannot, unfortunately, the urinary cannot, ammonia cannot measure directly. So that's why Robbie explained to us when we see the urine anion gap, if it's positive, that means that there's a deficiency in ammonia. And that means there's a loss of positive charge. That's another cause, can be ketone or lactate. If we gain negative charge, that means that the urine osmolality is like close to 0. And if we see the urine anion gap negative, and then we see there's a presence of ammonia. And I think that will be all.
Oh my gosh, you caught it. You got it 100% correct, which is so impressive. It's so hard. Amanda, I think you made Hugh Ting a RTA master now. With
Oh no! Oh my God! I'll try to catch up. Next time will be better.
Well, I'm sure next time will be better because you clearly your desire to learn and grow is incredible. And yeah, I think every next time will be better.
Thank you.
Yeah, but you have to acknowledge that this time was also amazing. I mean, this is a very complicated case, and I think you caught every small and large teaching point and summarized it in 4 minutes, which is not easy at all.
Thank you.
Marvelous job. Congratulations again on your fantastic news. Thank you, Amanda, for a great case. And hope some of you can join Yusuf and Yasmin's management reasoning session tomorrow. It'll start 3 hours from now, just to adjust your case. And Ricardo, I just saw your message. I won't be able to respond, but I'll tell you that you don't have to send an email. You just show up and present. I'll tell the whole world that Ricardo's been inspired to present on Sunday. So come join on Sunday too to see a Ricardo case. All right. Bye.
Bye-bye.